Good morning, everyone. I'm Saili Tarlekar, the Global Marketing Director for Arineta. Thank you for joining this Arineta-sponsored webinar today, featuring our distinguished guest speakers, Dr. Sujith Kalathiveetil and Dr. Sullenberger. They will be discussing strategies for establishing a thriving cardiac CT program and seamlessly integrating cardiac CT into the Cardiac Urgent Care Center. Dr. Sujith will dive into how to build a successful cardiac CT program, followed by Dr. Sullenberger's insights on the integration of cardiac CT into a cardiac urgent care center. We will also be taking questions from the audience at the end of the presentations. Now, I would like to go ahead and introduce Dr. Sujith Kalathiveetil. He is the Director of Cardiac Imaging for the section of Cardiology at Duly Health and Care. Duly is the largest independent multi-specialty group in Midwest with approximately 1,000 physicians. Dr. Kalathiveetil launched the cardiac CT at Duly Health. He plays an active role in utilizing cardiac CT for evaluating chest pain at the Duly Cardiac Evaluation Center, as well as CT for management of structural heart disease. Dr. Sujith, I welcome you and I request you to start your presentation.
Thank you, Saili. I'll go ahead here and everyone see my slides? I'll take that as a yes. Good, excellent. So my name is Sujith Kalathiveetil. I am the Director of Cardiac Imaging, as Saili pointed out. I'm with Duly Health and Care, and we are, I'll tell you more about our organization. I'll be speaking today about how to build a successful cardiac CT program. So a little bit about, Duly. We are a private multi-specialty practice of about 1,000 physicians with 45 cardiologists. And we offer a range of services across primary and specialty care. We serve over 2/3 of the Chicagoland suburbs. Our core philosophy is to provide high quality care that is outpatient based and cost effective. And a lot of that is driven by the fact that we have a sizable Medicare Advantage population. So everyone here knows cardiac CT is a vital tool in the contemporary management of heart disease. The challenge is that high quality cardiac CT scanners are generally expensive, and for this reason, they've historically been owned by hospitals. The cardiograph scanner allowed us to bring cost efficient, high quality cardiac CT into our outpatient focused independent practice. So, some lessons we've learned. We found two real keys for building a cardiac CT program. The first is a CT first strategy for evaluating chest pain, and the other is a CT first strategy for managing structural heart disease. So chest pain is a very unique problem for an outpatient-based practice. Historically, our triage nurses would reflexively send all of our patients with chest pain to local emergency rooms, where they are typically admitted for inpatient evaluation. And many of these patients did not have life-threatening chest pain, so hospital admission was often unnecessary. So Duly created a cardiac evaluation center, what we call a CEC, for patients with non-life-threatening cardiac symptoms such as chest pain, to provide rapid evaluation and on-site testing. And by providing expedited outpatient evaluation, our goals were to reduce healthcare costs and provide greater patient satisfaction. And to give credit where credit is due, we actually based our CEC off of the ambulatory care center that our colleagues at Capital Cardiology created. So we adapted it for our own geography, but they truly are the pioneers in this space. So I think everyone here is very familiar with the 2021 AHA-ACC chest pain guidelines. In these guidelines, coronary CTA or CCTA is the only test with a Class 1 recommendation and Level A evidence for the diagnosis and management of stable chest pain in patients without a prior history of obstructive coronary artery disease. So when these 2021 guidelines came out, it made it very clear to us that acquiring a cardiac CT scanner was vital for our practice. So Duly purchased the Cardiograph CT scanner and opened our CEC in January of 2022. Now, we chose the Cardiograph CT scanner for a variety of reasons. First, a small form factor is very space efficient, so it's really great for an ambulatory setting. The smaller field of view reduces radiation dose and limits visualization of non-cardiac anatomy. Again, this is the world's first dedicated cardiac CT scanner. It's also cost efficient compared to larger detector scanners, yet still provides excellent image quality. So I wanted to kind of go through our workflow that we use at our CEC for chest pain. So step one, a patient calls or presents to their primary care doctor, cardiologist, or urgent care center with chest pain. The patient is then referred to our CEC. A triage nurse at the CEC screens the patient to make sure inpatient evaluation is not indicated. Our second step is that the patient is seen at the CEC typically within one working day. And to be honest, our goal is to try to see these patients the same day. As soon as they arrive, EKG and labs, including a troponin, BMP, and CBC, are drawn immediately, and the patient is then placed on telemetry. They are then evaluated by one of our cardiologists or APPs. So this is the screening questionnaire that our nurses use when they get called about a patient with chest pain. So our first question is, does the patient have severe chest pain? Are there any signs of clinical instability, such as low blood pressure or severe dyspnea? And has the pain lasted for greater than 20 minutes? The AHA and ACC actually have a definition for what's severe chest pain. So severe is pain that's 8 or greater out of 10, that's crushing, or if there's a sense of doom. If they have any of these features, EMS is activated and they do not come to our CEC. The second question is, does the patient have a prior history of obstructive coronary artery disease? So has the patient had a prior MI, stent, or bypass surgery? And if the answer is yes, and if they still have, these are the same symptoms that they've had before, once again, EMS is activated. Our final question is, does the patient have a fever or cough, or have they tested COVID positive in the last 10 days? And if the answer is yes, they're directed to the ER. Otherwise, they come to our CEC. And honestly, the majority of our patients do make it to our CEC. So step 3, if the patient is identified to be an appropriate candidate, coronary CTA is performed, and typically this is done in the same day. We do perform rate control with metoprolol, diltiazem, and ivabradine. And if the patient has an elevated heart rate on presentation, let's say 90 to 120, we typically will rule out the patient for myocardial infarction, discharge a patient, pre-medicate them, and have them return the following day. We do this just for speed and efficiency, so the patient can be in and out of the scanner quickly and not spend excessive time for rate control. And then step 4, all walk-in coronary CTAs are read prior to the patient being discharged. Our goal is to discharge the patient within 2.5 hours of presentation. I would also add that Duly is part of the HeartFlow Unlimited program. All of our coronary CTAs at our CEC have FFRCT performed. For those of you who are familiar with HeartFlow, all walk-in patients are flagged as high priority within a 1-hour FFRCT turnaround time. Patients with obstructive coronary artery disease are started on guideline-directed medical therapy and arranged for prompt outpatient cardiac catheterization, typically in less than 72 hours. And patients with non-obstructive coronary artery disease are started in guideline-directed medical therapy and follow up in our office within 2 weeks. Our CEC is open Monday through Friday, 8 a.m. to 5 p.m. So on a given day, we have 12 elective outpatient CTs scheduled daily. And about 75% of these are coronary CTAs, the other 25% are structural CTs. On top of the 12 that we have scheduled, we save an additional 5 slots for walk-in coronary CTAs for patients who present with acute chest pain. On a typical day, we do 2 to 3 walk-ins. We've done as many as 6 on a walk-ins on a given day, but 2 to 3 is pretty typical for us. On a typical day at our CEC, between one cardiologist and one APP, we see 14 to 24 patients. So over a 2-year time period from 2022 to 2023, we saw 4,300 patients. In that same 2-year time period, 3,446 CTs were performed, and 2,410 of those were coronary CTAs. We have received the HeartFlow CT Quality Award every quarter since opening, and that's 9 quarters consecutively. And we have the highest FFRCT approval rate in our geography, which is the Chicagoland area. So this is just to show you our volumes at our CEC. So over a 2-year time period, our E&M volumes, the number of patients we're actually seeing, is nearly doubled. And our coronary CTA, or I should say our cardiac CT volumes, have steadily increased. And in 2024, we're on track to perform over 2,000 CTs this year. The second aspect that we found for growing a cardiac CT program is in the management of structural heart diseases. And there's multiple aspects to this. So one is for the evaluation of valvular heart disease. Second is for left atrial appendage occlusion. The third is for pulmonary vein isolation and overall management of atrial fibrillation. And finally, aortic aneurysm surveillance. So from a valvular heart disease standpoint, CT is used for assessing aortic valve morphology and stenosis severity. And particularly for patients with low-grade aortic stenosis, we can perform aortic valve calcium scoring and assess aortic valve orifice planimetry. We can also use CT for valve sizing that's both for surgical and transcatheter valves. And we can use our cardiograph scanner for vascular access planning for transcatheter aortic valve implantation. We can also, in patients with prosthetic aortic valves, we can do 4D CT to assess for leaflet mobility, and this is true for both mechanical as well as bioprosthetic valves. We can assess for leaflet thrombosis, and we can also assess for pannus formation. In terms of mitral valve disease, we can use CT for assessing mitral annular calcification prior to surgery, and also for planning valve-in-valve mitral valve implantation with transcatheter valve. CT is a vital tool, and again, we do this fairly regularly at our center. And then for the tricuspid valve, earlier this year, there was the first FDA-approved transcatheter tricuspid valve was approved for severe tricuspid regurgitation, and CT is very integral for planning transcatheter tricuspid valve implantation. So at Duly, we follow a CT-first strategy for aortic valve disease. If a patient is referred to our structural heart team for possible symptomatic low-grade aortic stenosis, we use CT as our first-line test to confirm aortic stenosis severity. And we favor this over dobutamine echocardiography and catheterization for the fact that it's faster, non-invasive, and generally safer and less expensive. If a patient has prosthetic aortic valves with elevated gradients, both surgical as well as transcatheter valves, we actually, again, favor CT as our first-line test over transesophageal echocardiography. We can assess for leaflet thrombosis and structural valve deterioration. Again, this is non-invasive, faster, and less expensive. Left atrial appendage occlusion, or LAO, is recommended in our 2023 ACC/AHA AFib guidelines for patients with atrial fibrillation who cannot tolerate long-term anticoagulation. And historically, we use transesophageal echocardiography for planning left atrial appendage occlusion. CT, on the other hand, has really come into the forefront as a better planning tool, and it offers a variety of advantages over TEE. So again, it's non-invasive and faster, and we have multiple studies showing that CT is associated with shorter implant times and greater procedural success rates. CT can also be used for post-implant assessment of left atrial appendage occluders to satisfy requirements of the NCDR registry. And studies again have shown that CT is more sensitive than TE, detecting complications such as device-related thrombus and peri-device leak. So in the upper left-hand corner is a Watchman device with device-related thrombus, and the lower left-hand corner is a Watchman device with a large peri-device leak, and you can see the absence of endothelialization and complete washout of contrast throughout the appendage. In the upper right-hand corner is an amulet device with a device-related thrombus, and the lower right-hand corner shows an amulet device with a large peri-device leak. So again, CT works excellently, not just for planning left atrial appendage occlusion, but also for the follow-up of it. So again, we use a CT-first strategy for left atrial appendage occlusion. Unless a patient has a GFR of less than 30 or a severe iodine contrast allergy, we use CT preferentially for planning left atrial appendage occlusion. In our practice, 95% of our occlusion cases are done based off CT. We use a very small minority are planned with TEE. And we also prefer CT for surveillance of left atrial appendage occlusion patients. We usually do a post-implant CT at either 6 to 18 weeks, and then we also do one at 1 year. And even long-term, there's a concern of a device-related complication beyond a year. Let's say the patient has a stroke over a year out from left atrial appendage occlusion. We again favor CT as our first-line test over TEE for its speed and non-invasive nature. And sort of, AFib on a bigger context, our electrophysiologists have incorporated CT early into their workflow for atrial fibrillation. So when a patient is referred to our EPs for AFib, they typically order a CT at initial consultation. As we all know, nearly every patient who undergoes a pulmonary vein isolation ablation will have a CT done for mapping. But our electrophysiologists realize the CT gives so much more additional information beyond just mapping the pulmonary veins. So we can rule out appendage thrombus prior to ablation with delayed imaging. We can assess the septum for the safety of transeptal puncture, and we can assess for coronary artery disease. So when our electrophysiologists are considering different antiarrhythmic therapies, they can determine the safety of using a Vaughan Williams 1C antiarrhythmic if there's no obstructive coronary artery disease. And finally, we can again use CT to assess appendage anatomy for future or concomitant left atrial appendage occlusion at the time of pulmonary vein isolation. And finally, our practice has made CT the preferred test for yearly surveillance of thoracic aortic aneurysms that are not confined to the aortic root. And we know that CT offers greater accuracy over echocardiography and even has a superior spatial resolution to MRI. We can also use the same CT to assess for aortic valve morphology. We know about the strong association between bicuspid aortic valves and aortic aneurysms, so we can get that additional piece of information. And we can also use CT to detect preclinical coronary artery disease in our patients who have aortic aneurysms. So in conclusion, our cardiograph scanner has brought cost-efficient, high-quality cardiac CT into our outpatient-focused independent practice. We found two major keys to growing our cardiac CT program. First is a CT-first strategy for evaluating chest pain, which is very much in line with the 2021 ACC/AHA chest pain guidelines. And second is a CT-first strategy for structural heart disease, specifically for aortic stenosis, for assessing prosthetic aortic valves, for left atrial appendage occlusion, for overall management of atrial fibrillation, and for surveillance of thoracic aortic aneurysms. Thank you all for your attention.
Great, thank you.
Thank you, Dr. Sujith. I would like to welcome Dr. Lance Sullenberger right now. Dr. Lance is a non-invasive cardiologist in Albany, New York, and Chief Operating Officer of Cardiology Associates, and a fellow in Society of Cardiovascular CT, as well as a founding member. He began reading CTAs in 2006 at Walter Reed Medical Center and has always been interested in applying cardiac CT to patient care. Dr. Lance will be talking about integration of cardiac CT into a cardiac urgent care center. Dr. Lance, the virtual floor is yours.
Thank you very much, Siley. I really appreciate the introduction. So let me just pull my slides up. What I'd like to talk about today is integration of cardiac CT into a cardiac urgent care center. Now, I'm going to tell you a little bit about Capital Cardiology Associates. We're a fairly large cardiology private practice with 35 cardiologists, including non-invasive electrophysiology, structural, interventional, advanced heart failure. We have now over 21 advanced practitioners, and we have 3 major office locations that are expanding. Now, if you go back over 10 years, we encountered this issue that many cardiologists have encountered, which is the problem with patients presenting with cardiac symptoms to an emergency room. And it's quite frustrating. This was in 2013, when things were actually better in emergency rooms than they are now, COVID and post-COVID. So part of the issue is you have no control when you're there over imaging, that frequently the patients are seen initially by hospitalists, which delays testing or creates observation hospital stays. That the testing in the ER sometimes can be redundant and unnecessary. And like I said, it leads to these inappropriate observation admissions. So we wanted to create a cardiac urgent care center in our office. We said, why have these patients go to an emergency room? Could we just create an area within our office space and tell patients, instead of going to an emergency room, why don't you just come to our office? And we'll tell primary care providers and others, like, if you have those types of patients, they don't even need an appointment, just send them in. That would allow us to control the imaging and avoid unnecessary admissions. So what we did is we created in an open space in our office 6 bays. At the time, it was just 6 bays, and purchased telemetry. I actually went on eBay and purchased telemetry from a closing cardiac rehab center in New Jersey. And they actually brought it up to us because telemetry was expensive. We didn't know if this would even be successful. We hired an RN with cardiac CCU experience or ICU experience. We had our lab increase analysis for stat troponin and BNPs. We educated our triage nurses, which was extremely important in this, and that when patients called in and said, I had chest pain, as Sujith recommended earlier, instead of saying, oh, go to the ER, we had to train them to say, if they call in with any symptoms like shortness of breath, palpitations, chest pain, that they should just come into be directed into the office rather than being directed into an emergency room. And then we did a lot of outreach to local primary care physician offices. I gave a lot of talks around that time, just saying, you know, if you have somebody in the office and you're concerned about them, but you know, they're not having an acute MI based on the EKG, like, why don't you just send them over? We also did ER education so that the ERs became familiar with what we offered. And also, you know, at the time, we didn't know if the ERs would be upset. They actually were quite pleased that there was a walk-in cardiac evaluation area available. So we take patients with chest pain, with shortness of breath, palpitations, severe hypertension, AFib with RVR or new onset AFib, urgent pre-ops, syncope. Those patients are triaged by our nursing staff. Each patient gets labs, EKG, vital signs performed. And then an advanced practitioner will perform the initial evaluation. And then after it's decided what testing is going to be done, or in conjunction with the advanced practitioner deciding what testing will be done, the patient's seen by a cardiologist. And so it's sort of a mix of advanced practitioners supervised by cardiologists, both of whom see the patients. We created space, as Sujith showed on the CT scanning. We did it for echo, for stress testing, even nuclear imaging, and definitely for CT, having available add-on space available. The CT scanning could include things like calcium scoring, CT angiography, triple rule-outs, as well as just regular chest CTs to rule out pulmonary embolism. And then obviously MCOTs for patients with palpitations or possible AFib, and then ultrasound. We do a lot of ultrasound studies for DVT, for vascular. I can tell you that now the orthopedic surgeons love us, because if they have a swollen leg, they just send the patient over to our ECA, where they get an immediate ultrasound for DVT. If it's positive, the patient's seen by us. We put them on anticoagulation. The orthopedic surgeon never has to worry about it. If it's negative, they just go home. So we initially came up with this idea in 2013. We opened in March of 2014. And since that time, you can see, and I think in 2014, we had about 700 total visits to the ECA, which at the time was 6 bays in our Albany office. Since then, it's grown exponentially. Even through COVID, we stayed open. We never closed during COVID. Even during COVID, we had a slight downturn, but as did most medical practices. But since then has just increased dramatically. You can see that the total visits, which is here in black, and the distinct patients, which is in red. We have some repeat people come in, especially for congestive heart failure symptoms, or some of the palpitations come in on a couple of occasions. In 2023, the data which is not on here, we had a total of 14,000 distinct visits with 9,000 distinct patients. What also this has allowed, so it has become not only a source of patient visits, but a source of new patients. So of these distinct patients you see on a daily basis, we're looking at about a quarter to a third as new patients, which has also allowed us to leverage the hospital, right? We don't have to depend on the emergency room for new patients. We have them absolutely just walking into our office on a daily basis. So currently we have 2 sites. One is in our Albany office, which is expanded now to 14 bays. And again, this is within the office itself. The cardiologists who cover the ECA, who see the patients along with the advanced practitioners, are also seeing their own regularly scheduled office patients. The mean number of patients seen per day in Albany is about 41 patients per day. I think the highest number we've seen so far is about 65. We have a second site that opened in 2021 in Clifton Park, which has 12 bays, and that's about 21 patients per day. So on any one day, I've got 60 over 60 patients unscheduled walking into 2 different office sites. When we originally created this, we thought probably 85% of the patients would be able to go home, and about 15% would be admitted to the hospital. And actually, it's been much greater than that. So 96% of the patients are sent home, and 4% of the patients are sent to the hospital. And that can be either through a direct admission to the hospital. Sometimes we have to send them to the ER either because there's non-cardiac issues going on, like a GI bleed or pneumonia, or because there's no beds available for direct admission. And then also, obviously, some of the patients come in, rule in for an MI, and go on to need to go to the cath lab. So for CT imaging, when we originally started, we had a 64 slice GE Lightspeed in our Albany office, VCT. And we used that from 2014 when we started it to about 2019 when we got our first cardiograph. The cardiograph, I can tell you, has been a much better CT scanner because of the issues related to, you don't have to have as adequate of a rate control because it's one heartbeat, and just the throughput is much faster. We utilize about CT in about 18% of these ECA visits. Prior to the 2021, and even before that, the NICE guidelines sort of giving validity to coronary CT angiography, we would do a lot of calcium scoring. So we would do what's called, just for approval processes or prior auth, so we didn't have to worry about the process. We would do a lot of what's called poor man's CTA, which was a calcium score and a stress test if the patient's able to walk. Currently, we do a lot more coronary CTAs. Of that, we do about 3,000 coronary CTAs a year, a total of 5,200 total CTs, but about a little over 3,000 are coronaries, and probably a quarter of those are from the ECA. It's at least once a week or once every 2 weeks that in one of the 2 sites, somebody shows up with a PE, showing up with either shortness of breath or pleuritic chest pain. And then we do a lot of triple rule outs. We just had somebody with an incidental dissection noted on a CT scan here earlier this month. So when I tell, when we try to spread the gospel of having an cardiac urgent care center and how much better patient care is and how much better it is for patients themselves, the whole experience, than going to an emergency room, I tell these groups that visit, like Duly when they visited pre-pandemic to look at us, as that you have to have a CT scanner to do this. You can't do it with just echo and a stress test. That the CT scanner really forms the nidus because you're able to do so much in the evaluation of patients, whether it's looking for just coronary calcification to get an idea about overall risk, or whether you're doing a CTA to look for obstructive disease, but also PE and dissection. The other part of this is that you have to be very comfortable discharging patients out of your office who've presented with chest pain. And obviously, in the age of high sensitivity troponin, that's become easier. However, having a CTA, whether it's read just primarily by the reader, whether you've got FFRCT like Sujith mentioned, or we do Clearly. We've been using Clearly for the last couple of years, which is vessel analysis, and soon we'll have ischemia. Start using ischemia next month with Clearly. Those things allow you as a provider to disposition the patient in a safe manner, and everybody feels better. The patient feels better, you feel better because you've provided good care and you're comfortable with the diagnosis of non-cardiac chest pain. So that's the end of my presentation, and I'll be happy to take any questions that people may have.
So let me go ahead and share my screen quickly. We already have some questions here. Give me one sec. Do you see my screen?
Yes.
Okay. So we have our first question is there a patient weight limit beyond which the image quality would deteriorate substantially or the scanner cannot handle at all?
I
I can, yeah, go,
Lance,
go ahead,
You-
Sujith, and I'll give you
Thank-
my opinion and you do yours.
Yeah, thank you. I suspect there's some similarities there. I think it goes that, there is a weight limit, but I think more so than the weight, it's the weight distribution. There are certain patients who are short who, even if their weight is less than 450 pounds, there's going to be image quality issues. The largest patient that we have done a coronary CTA on our scanner and still had adequate image quality, where it actually was still accepted by HeartFlow, was a BMI of 53. So again, there is a weight limit, but I would say more so than just that, it's also the weight distribution. Lance, you're welcome to offer your thoughts.
Yeah, we have a cutoff of a BMI of 45 for coronary CTA with special exception. Now, I'll tell you from running PE scans and aortas through there that you can do greater than a BMI if you're not looking at the coronaries themselves. But physics is physics, and you have to be able to get enough energy into the vessel to be able to discern what's vessel and what's calcium and what's plaque. The other component of this, when we first started, we had like the first, I take that back. We had the second cardiograph scanner in the country. I actually had to call before we settled on the cardiograph. I had to call Ireland to ask them about their experience with it. They had no experience with doing full chests, because we were very concerned that we were going to have patients who either would not fit in the scanner because of body size, or that we couldn't see the pulmonary vasculature enough to rule out PE, because we had a thriving ECA at that time. I can tell you that neither one of those issues has ever come up since we now have 2 cardiograph scanners. We've never run into the problem where a patient couldn't fit in the scanner, and we also have good visualization of all the pulmonary tree.
Thank you. So we have one more question, and they say, would you do a CT for patients with ACS in your centers?
So I'll start with that one. It depends on what the meaning of ACS is. Obviously, somebody who's got a ST elevation MI, which occasionally walks in, but patients have chest pain and the triage nurses recognize that it's an ST elevation MI, and we immediately send them by ambulance to the cath lab. So there's that issue. There's other issues of patients presenting with chest pain that have a positive troponin and no real EKG changes per se. Well, that patient, if you have a high enough baseline risk, that's the type of patient that I would not do a CT on, but would more likely just send them to the cath lab. However, you also have patients presenting who have positive high sensitivity troponins with stories that aren't as as classic, and you're trying to figure out, is this myocarditis? Is this Takotsubo's? Is this something else? And those patients we will run through the scanner to see if they have obstructive coronary disease. In addition to that, sometimes when we're just trying to figure out what testing is best, I have my APPs. So while we're waiting for labs to come back, and we don't know what the troponin is, but I'm sorry, we don't know what the creatinine is on the patient. We also don't know the troponin, but we know risk stratification is going to need to occur. I'll have them run through the scanner as a calcium score. So if you have a low calcium score of, say, less than 500, you know that patient could easily get a coronary CTA. On the other hand, if the patient's calcium score comes back as 1200, you know that patient, if their troponin's negative, is probably going to be more suitable for nuclear imaging or PET imaging rather than getting a coronary CTA as the follow-up. So we use it in all sorts of manners like that.
Yeah,
Thank
I
you.
agree. I agree. I was going to say that, yeah, it's a nuance. When we say ACS, it's a spectrum.
Yeah,
Clearly the people on the unstable end of the spectrum, like a STEMI or someone with a very suspicious story who's still having active chest pain, I would not CTA those people. They should clearly, EMS should be activated. They should go to the hospital. But there's a lot of patients who come in with other types of symptoms where we think of pericarditis and the troponins
right.
are mildly elevated. And I think it's very reasonable to allow for CTA there. And if they have normal renal function, the amount of contrast we use still wouldn't preclude a cath later that day if it came down to it.
Right.
Thank you. Our next question is, what are some of the economic barriers that you've come across, if any?
Are they referring, I'm not sure if they're referring to CTA or having a urgent care center, but I can,
Having an urgent care center or a cardiac CT program.
okay. So I'll take the urgent care center aspect. I think for us, obviously, when you're looking at it just from a business standpoint, that every new project takes overhead. It's an overhead of space. It's an overhead of having staffing. We certainly have more nurses, more MAs, and more advanced practitioners than we would without an urgent care center. But when you take into account the number of new patients, the number of total visits, and the downstream testing, it overall is certainly a net benefit. Now, the other question that comes up is we just made a group decision to waive any prior auth for testing that had to be done in the ECA, and sort of like we'll do it and ask for forgiveness later. This comes up mostly in the area of CT, mostly with insurance companies that are sort of behind the curve in the use of CT. And it's become much less common, but usually can be cleared up through a peer-to-peer. And I just, tell the person who, the physician who's on the line, I just say, well, the person came into our office. You need to understand we have an urgent care center in our office. So they came into our office with chest pain. We scanned them and were able to send them home. That saved your insurance company a lot more money than if they'd have shown up in an emergency room, been admitted for some sort of stress testing or nuclear stress testing or whatever the following day after their observation admission. And most of the time it gets approved after that.
Thank you. We have one more question. As an expert in the field, do you believe in precise performance of PCI? For example, using CTA to plan coronary interventions?
I can speak to some of that. I would disclose that I'm not an interventional cardiologist, nor is Dr. Sullenberger, but as a non-interventional clinical cardiologist, yeah, I think that one of the advantages of CTA is that we can plan PCI. FFRCT with heart flow is a really nice tool for a variety of reasons in this regard. So one, we can detect functional lesions, so we can get physiologic information off of our CTAs, not just anatomic. But also too, it kind of just baked into heart flow. It has a lot of PCI planning data in there. For example, we can actually in heart flow get the optimal fluoroscopic angles for lesions. We can actually calculate. So a lot of times if there's a very eccentric lesion that I see on an FFR CT in my FFR report, I'll actually put in there, this would be the optimal fluoroscopic angle to lay this out, which for my interventional partners, they greatly enjoy. Also, all of my interventional partners have the HeartFlow app on their phone. So when they cath one of these patients, before they actually begin the case, they actually will pull up the FFR CT data on their phones, and they can already have an idea what the working angle is going to be. So yeah, I think CT is very, very nice in terms of augmenting PCI, establishing a strategy, figuring out what lesions you should go after.
Thank you, Dr. Sujith. My next question is, do you send images to the referring doctors?
So send images of the CTA to the referring doctors. We send the report to the referring doctors. We have, for our patients, as I mentioned, we use Clearly, which is vessel analysis, which creates not only a report for the physician, but creates a nice, appropriately worded layperson report for each individual patient on what their vessels looked like on the CT scan, and even shows them their own pictures of their coronary vessels.
Thank you. Next question is, what was the impact of implementing a cardiac CT program on your existing nuclear volume?
I can share with you our experiences. The answer is it's multifactorial. So we have found several changes in terms of the way we do diagnostic testing with going with a CT first approach. So the amount of diagnostic tests we were doing dropped dramatically. The amount of nuclear stress tests we were doing for just de novo chest pain for patients without a prior history of obstructive coronary disease dropped dramatically. So initially we did see a drop in our nuclear volumes, but ultimately that drop actually attenuated and actually started coming back up, because once these patients get revascularized, we really do lean on functional imaging for surveillance of these patients. So yeah, I think upfront, you will see a drop in nuclear volumes for patients with just chest pain. But once patients get revascularized, we still rely on nuclear imaging heavily. And as Dr. Sullenberger alluded to, now we finally got our PET program up and running. When we have patients with larger BMIs, BMI above 45, actually even above 40 now, we do consider PET in those patients as well too, because the image quality is so good and the attenuation correction is good. So I think that, nuclear stress testing for just de novo chest pain, I think should appropriately drop when you do coronary CTA, because it's a better test, for many patients. But ultimately, for people who get revascularized, it still has a very powerful role.
Yeah, I would agree with that. That we see we've had CT since 2006 here, since even before I joined this group. But as CTA itself has become more accepted, first through the NICE guidelines out of Europe, and then later through the ACC guidelines, that we see a drop in nuclear imaging, like you said, as a first line test. I mean, nuclear imaging and SPECT imaging, as everyone realizes, is on the way out. It's good for, somebody has coronary disease and has been revascularized and you need to look for ischemia. But for the initial evaluation of a chest discomfort patient, you could miss tons of non-obstructive disease if you don't either have a calcium score to go along with that nuclear test, or other means of looking at the coronary vessels. I mean, PET imaging, if in the right situation, is a much better way, because at least if the patient has coronary calcification on a semi-quantitative basis and whether or not they have ischemia. So I look at it as, if the patient has a large amount of plaque burden, and I already know that, especially if they're of a higher BMI, that person's better for PET imaging. If a patient if we don't know they have a lot of plaque burden, but they're a heavier patient, they're better for PET imaging, because I'm going to know whether or not they have non-obstructive coronary disease or obstructive coronary disease. I think in the absence of either of those, if I've got a patient with de novo chest pain that I'm not sure if they have coronary disease, or they have a calcium score at any time in the past that was on the lower side, a CTA is a better test, especially when you have FFRCT and clearly using ischemia, because you can get all the information that you need right there, both a functional and an anatomic test.
Thank you. Dr. Lance, I believe I have an urgent care question for you.
Mm-hmm.
Will reimbursement be the same as hospital or the same as an outpatient setting in an urgent care setting?
Yeah, so that's a great question. So we're an independent practice, so we don't have HOPS, reimbursement. We have the lower reimbursement that most private practices face. In terms of the imaging test, obviously, that's a fixed rate by CMS and by the payers. In terms of the patient visits, what patients really like is it's an office visit, and it's a copay of an office visit, and not the copay of an ER visit. So, which is usually, it can be up to 10 or 20 times greater than the office copay or coinsurance amount that has to be paid. So from a standpoint of global healthcare dollars, it's a much better way to keep costs down and actually decreases the amount of testing that's done in terms of hospital stays, and certainly decreases the number of beds taken up by patients who have non-cardiac chest pain.
Thank you. And I have one last question here. What is compliance of the patient after they see their CCTA?
Compliance with medical therapy, I think it's great. I find it particularly in patients, for whatever reason, in our society, statins in particular seem to get a really bad
Yeah.
rap, even though it's one of our most powerful, life-saving therapies. When I have patients who have cholesterols that clearly meet criteria for statin therapy, and they're reluctant about it, when I actually am able to show them a picture of their arteries and show that they actually have plaque, that usually is a very powerful negotiating tool for getting people to be much more compliant with therapy.
I agree. I think, and actually, we're a fairly heavy area in calcium scoring, and many patients are fixated on their calcium score. Even when they have a coronary CTA, they're fixated on their calcium score. So they might have non-obstructive disease, but they have a calcium score of, let's say, 400, and that number, oh, I'm a 400. That number will drive them to be more compliant than just the fact that, yeah, you have a lot of plaque that, it's not obstructive. So I think that helps. I think seeing their vessels helps. Certainly demonstrating to them non-calcified plaque and calcified plaque within their vessel. We can bring it up on the computers in our room. Helps patients. And like Sujith said, convincing a patient in the current world to take a statin is like a win every day, because you're fighting against the internet, which is a tough competitor.
All right, so those were all the questions. I want to thank both our speakers today for your presentations. It was very insightful. And I also want to thank the audience for joining us for this webinar. If you have any additional questions for us at Erineta or for any of our speakers, feel free to send them at marketing@erineta.com. Thank you, everyone.
Thank you
For having us.